So coming to the fever, what is fever? It is single oral temperature of more than 38.3 degrees centigrade or more than 38 degrees centigrade sustained for more than 1 hour. So what is the important principle? Fever is a physiological response, not a diagnosis. Then causes of fever are infectious, it can be non-infectious. Infections may be bacterial, viral, fungal, parasitic. Non-infectious can be drug, fever, autoimmune disease, malignancy, DVT, PE, pancreatitis, transfusion reactions. Now coming to the fever patterns, less important than previously believed. Continuous is enteric fever, intermittent is malaria and sepsis, relapsing is malaria and borreliosis, palabstrine is Hodgkin lymphoma. Then ID fellowship question during fever evaluation. When you see a fever, ask whether it is acute or chronic, community or hospital acquired, immunocompetent or immunocompromised, localizing symptoms, travel history, animal exposure, recent procedure, antibiotic exposure. Then leukocyte count normal is 4,000 to 11,000. Uh, uh, number. Common causes are bacterial infection, steroids, stress response, surgery, trauma, neutrophilia suggest acute bacterial infection, steroid therapy, and inflammation. So these are the conditions where neutrophilia is present. What do you mean by left shift? Means if there are increased bands or metamyelocytes, then we call it as left shift, suggestive of active marrow responses. Then is the lymphocytosis, that is seen in increase in lymphocytes, viral infection, infectious mononucleosis, pertussis. Then eosinophilia, it can be in parasitic infection, drug reaction, allergic disorder. Leukopenia, very important in infectious disease because it is seen in dengue, typhoid, severe sepsis, viral infection, and bone marrow suppression. Then coming to the clinical pall, a septic patient with WBC 2000 may be sicker than a patient with WBC 20,000. So leukopenia and sepsis is often a bad prognostic sign. Now coming to the CRP, that is C-reactive protein. This is produced by liver and it is stimulated by IL-6, IL-1, TNF alpha. So if there are more inflammatory cells, they will secrete this and it will affect the liver. Then kinetics is, it rises within 6 to 12 hours. It reaches peak at 24 to 48 hours and half life is about 19 hours. So what are the important clinical uses? It helps in diagnosis and it supports inflammation. Monitoring is more useful than diagnosis. Is CRP falling? Means the person is improving. Is source control adequate? Is treatment working? So CRP can be evaluated in infectious, that is bacterial infection and fungal infection, non-infectious rheumatoid arthritis, vasculitis, trauma, surgery, malignancy. But elevated CRP doesn't always mean that it is bacterial infection. So common ID fellow mistake is CRP is high, start antibiotic. Wrong, need clinical syndrome. Mistake 2 is your CRP is normal but no infection. Wrong. It can be infection, early infection may have normal CRP. Now the third mistake is that fever persists, antibiotics are failing. Not always. It can be drug fever, it can be abscess needing drainage, it can be wrong diagnosis, thrombosis, autoimmune disease. The three questions every ID fellow should ask: that what is causing the fever today? Is the trend of leukocyte count improving or worsening? Or does the CRP fit in the clinical picture? So consultant level interpretation A patient has 39 degrees centigrade, WBC 22,000, CR 250 milligram per liter. So does this prove bacterial sepsis? No. It increases suspicion, but diagnosis require clinical syndrome, microbiology, imaging, response to treatment. So the ID consultant approaches that fever, WC, and CRP are just the clues; they are not the diagnosis. So this is important to master about the fever. So, case example is a 45-year-old presents with fever for 10 days, temperature 39 degrees centigrade, headache, no cough, no dysuria, no diarrhea. So, now let's evaluate this fever, whether it is acute or chronic fever. So, why you should ask this? Because differential diagnosis changes completely. If the fever is of less than 2 weeks, then it is called as acute fever. Common example is malaria, dengue, enteric fever, viral illness, acute bacterial infections. If it is of chronic fever that is more than 3 weeks, then you can think of tuberculosis, infective endocarditis, HIV, malignancy, autoimmune disease. Here our patient is having fever for 10 days. So it is acute, subacute fever, and most likely chances here are of enteric fever or malaria or viral infection, and less likely tuberculosis. So question 2 is community acquired or hospital acquired. So why we are going to ask this? Because different organisms are there for both of them, and resistance pattern is also different in both of the cases. So community acquired may be typhoid, malaria, dengue, pneumonia, whereas hospital acquired, then you should think of MRSA, MDR, gram negative bacilli, catheter related infections. Example is patient develop fever on day 7 of ICU admission. So now you should think of VAP, CLAPSI, COTI, drug fever, but you should not think of dengue or typhoid. Now, what third questions you can ask here with the patient is immunocompetent or immunocompromised. So, the organism list again changes dramatically. Immunocompetent are the common pathogens, whereas immunocompromised, it can be fungal, it can be CMV, it can be PCP, nocardia, cryptococcus. Examples here are patient kidney transplant of fever 3 weeks. So, these are the situations. Patient may have undergone kidney transplant, or maybe then having fever for 3 weeks. Then you should ask immediately current immunosuppressants given to that person, or CMV prophylaxis or neutrophil count. So if these things are being given and disturbed, then you can think of this type of organisms. So other example may be any localizing symptoms. So this is the most important thing, because you see from head to toe and what system is involved, where the infection is, where the problem is. So symptoms like headache, neck stiffness, confusion, that shows that CNS is involved. And then you should think of meningitis and encephalitis may be the reason of infection and leading to the fever. So fever, headache, or photophobia, if all these things are present, then you should think of this. Otherwise, respiratory can be cough, sputum, or breathlessness. So if these symptoms are present, then along with fever, you should think of pneumonia or tuberculosis, and you look for the chest x-ray and productive cough. Then coming to the cardiovascular thing, so murmur or embolic signs. Think of infective endocarditis. Example is fever plus prosthetic valve, then blood culture and echocardiography. Then coming to the gastrointestinal, symptom is diarrhea and abdominal pain. Then think of enteric fever or liver abscess. Example is fever plus right upper quadrant pain. and you'll go for liver imaging. That is going to help you out with the diagnosis. Genitourinary will complain of dysuria and flank pain, and then you should think of pyelonephritis. uh, Example is fever plus dysuria, then you should go for urine culture. Then you come out with the diagnosis of infection, if it is infectious fever. Then the travel history, many diagnoses are hidden here. Where did patient travel, when, what activities? So these all things will give you clue. Mumbai resident returned from Kenya, then presenting with fever and chill. So Kenya से आ रहा है, that means he is having malaria. Travel history may be the most important thing, and you should ask for. Animal exposure like rabies and Pasteurella infection, cat exposure, cat scratch disease, livestock exposure, then brucellosis, then farmer with the fever for 1 month, joint pain, animal exposure, then you think of brucellosis. Now, whether it is recent procedure or devices, if anything happen like that. So, if there is central line, you think of CLAPSI. Urinary catheter is there, you think of COTI. Prosthetic valve endocarditis may take place. Orthopedic implantation, prosthetic joint infection can take place. Like fever with 2 week, fever of 2 weeks after valve replacement. Then you should understand that it may be due to the prosthetic valve endocarditis. Then recent antibiotic exposure. So why it is important? Because that changes the microbiology. For example, recent antibiotics increase the risk of resistant organism, fungal infection, clostridium difficile infection. So this thing may happen if the person is on antibiotics. Then patient receiving meropenem for 3 weeks now develop fever. So it may be due to candida infection, it may be due to dung fever, it may be due to any resistant pathogen. So not simply give more meropenem. It's done. So how an ID consultant should think? That is, suppose a patient is having fever for 15 days but no cough, no dysuria, no diarrhea, no weight loss, no night sweats, so no infection. So question is acute or chronic? Then it may be subacute or chronic because it is 15 days. Community or hospital? It is community. Immunocompromised? No. Localizing system? No. You should ask for travel, you should ask for animal exposure, because fever is there and you want to see the reason of fever, that why fever is there, whether it is infectious or not, you just want to find out. So you should ask for such questions where you can rule out any cause of infection. So now the top differentials become tuberculosis, lymphoma, infective endocarditis, and autoimmune disease. So notice that we reached a focused differential before ordering a single test. That is the hallmark of infectious disease practice, that history first, then microbiology, and then in the end antibiotics. So this is how you should look for. Now why we get acute fever and why we get chronic fever? What is the pathophysiology? So you should know it. Why we are telling that in these infections only we will get acute fever, that is less than 15 days. So this is important, that most people memorize it like acute fever for infection and chronic fever for TB, malignancy and autoimmune disease. But you should know the reason. So what causes fever? Fever occurs when pyrogenic cytokines, they raise the hypothalamic set point. So the main cytokines are IL-1, IL-6, TNF alpha, IFN gamma. So these stimulate the prostaglandin E2 production in the hypothalamus, and that will lead to fever. So it results in vasoconstriction, shivering, and increased heat production. So these cytokines, they come out and that will lead to prostaglandin E2, and this will set the temperature of the hypothalamus at higher temperature. and due for to reach that temperature, body will try to you will see vasoconstriction, shivering, and increased heat production. So now the body wants higher temperature. So why is fever acute? Acute fever occurs when there is sudden strong inflammatory response, that is pneumonia, pyelonephritis, dengue, malaria, influenza. Pathogen enters the body, and your immune system recognizes PAMPs, and then the macrophages and dendritic cells, they release the interleukins and this, because they want to clear the infection. Then fever develops rapidly. So the infection is usually newly acquired, rapidly multiplying, and produce the strong inflammation. So example is pneumococcal pneumonia. Bacteria multiply rapidly in alveoli, then alveolar macrophage release IL-1, IL-6, TNF alpha, which will lead to high fever, leukocytosis, and high CRP within 24 to 48 hours. Then why does fever become chronic? Chronic fever, it occurs when the immune system and the disease, they reach a prolonged battle state. So the stimulus is persistent, not eliminated, continuously stimulating the immunity. So the body keeps producing cytokines for weeks to months. Example is tuberculosis. Why does TB cause chronic fever? Tuberculosis survive inside the macrophages. Instead of rapid destruction, macrophages, they ingest the bacillus. Bacillus survive intracellularly. T cell response develop, granuloma formation take place, cytokine continue to be produced. Now here the TNF alpha and IFN gamma are there. So they will result to low grade evening fever, night sweats, and weight loss for weeks or months. So the organism is never completely clear, it is always there. Infective endocarditis is your example too. So why prolonged fever in this case? Infective endocarditis, it creates a protected bacterial nidus, you know that. So vegetations are there and they shield the bacteria. Similarly, they prevent the immune clearance. So bacteria remains there. Continuous bacteremia is there. A little bit of bacteria is going in the bloodstream with the blood, with the flow. So continuous cytokine release will take place and result for weeks. So fever will be there for weeks until valve infection is treated. So autoimmune disease, no organism is present. Example is SLE. Immune cells, they continuously activate each other, and then cytokines, they remain elevated because immune cells are there, and it is autoimmune disease. So IL-1, IL-6, TNF alpha. Then what will happen? Persistent fever will be there despite no infection. So why does TB cause low grade fever while sepsis cause high fever? So why does TB is causing low grade fever? This is favorite consultant level concept, that in sepsis huge cytokine surge is there, and that is cytokine storm, and this leads to temperature of 39 to 41 degrees centigrade. Whereas in TB, persistent but moderate cytokine production is there, and then you should think of smoldering inflammation. Evening rise temperature is there, and that too is of 37.5 to 38.5 degrees centigrade, means low, not that much of high grade temperature, low fever, low grade fever you can say. So why are night sweats common in chronic fever? During the day, cytokines accumulates, temperature rises. At night, hypothalamic set point falls. Body tries to lose heat. So you find profuse sweating. And this is seen in TB, endocarditis, and lymphoma. So here the concept is acute versus chronic immune response, that in acute fever predominantly innate immunity play role. Cells are neutrophil and macrophages. Cytokines are IL-1, IL-6, TNF alpha. Duration is in days. and examples may be pneumonia, UTI, and dengue. Then in chronic fever, you will see predominantly adaptive immunity. T lymphocyte and activated macrophages, they play a role, and IFN gamma, TNF alpha, and IL-6 are the main cytokines, whereas duration is weeks to months. Example is TB, endocarditis, HIV, and autoimmune disease. Now the here the consultant pearl is, when you see fever, is this a rapidly multiplying process causing an acute cytokine surge, or a persistent stimulus is there which is causing chronic immune activation? This you have to think, that what type of fever is there, what type of immune reaction is happening in your body. This fever is telling you this. Acute fever is telling you that when this infection or the bacteria present is multiplying at fast rate, and it is an active infection. So that single question explains: pneumonia causes acute fever, tuberculosis causes chronic fever, endocarditis causes prolonged fever, autoimmune diseases mimic the infection with chronic fever. So this immunological framework is how infectious disease consults approach fever rather than simply memorizing differential diagnosis. So this all is about the fever in cases of infection. This is what chat gpt, when I asked question with chat gpt, I got this answer, and for revision purpose it is good, but this can be other things can be added by knowing many other references and articles. You can ask from chat gpt too, or you can go through your books and read there. If you have found any um something wrong here, that can be written in the chat uh, chat box, or you can say comment box. So thank you very much. If you find this helpful, you can subscribe to this channel.